Yeah. Good morning, good afternoon, and good evening. My name is Frits van Es, and I'm together with Ruud Verheusel, the coordinator of the healthcare section of PUM. PUM, we all wish you a warm welcome in this webinar about the professional basics of COVID. For our PUM volunteers and for you, this COVID period is difficult, but also new. COVID makes it impossible to travel, and it's all a difficult time for all of us. But at least PUM can do something, share knowledge about this virus. One of our volunteer experts is Liesbeth. She and Patricia work at the Erasmus Medical Centre. The Erasmus Medical Centre is the main university hospital in the Netherlands with knowledge about the COVID virus. We are honored that they are willing to give an update on COVID. Thank you, Patricia and Liesbeth. The webinar is organized by PUM. The staff of PUM is supporting this on the background. I want to thank them. I hope the technical part will function well. The webinar will take about 1 hour. We will tape this meeting. Questions can be sent by email afterwards. The email address is shown on the last slide. But during the session, you can also ask questions or remarks by the Q&A. The Q&A site is, you can use it by typing on the site like a chat. And we would like to try to give the answers on the questions during the presentation, but at the end. You can ask for a certificate for following this webinar. How? We will show you in the information you will receive later. I wish you a good meeting, and we will now switch to Liesbeth and Patricia. Thank you.
I'm not the first speaker, it's Patricia.
Thank you, Frits, for this warm welcome. And I'm very pleased that I am able to share some of my knowledge and experience about COVID-19 with all the people around the world in order to improve healthcare in different countries. Just trying to figure out some technical problems. And then we will start the presentation. There we go. Wonderful. Okay, so today I will give you a brief update on COVID-19, and I will talk about different aspects of this disease. First of all, I will go and introduce myself and also Liesbeth, who helped me with this presentation. Liesbeth, maybe you can introduce yourself.
Yes, can you hear me? Yes, I am Liesbeth van Ewijk. I am registered nurse and Bachelor of Education at the University Medical Centre Erasmus. I am staff advisor for acute care, education and simulation. And I'm also PUM volunteer now in Bangladesh and Georgia. I am working in the hospital, most in the children hospital, and for this presentation I can answer the questions for the nurses.
Thank you, Liesbeth. I will also shortly introduce myself. I am Patricia Eikemans. I am an internal specialist and specialized in the subfield of acute medicine. I also work at Erasmus Medical Centre in Rotterdam, the Netherlands. And I have been working on the COVID unit in our hospital and also on the emergency department. I work with COVID patients every day. I furthermore have a PhD in microbiology, and well, I think I can expose you to some of the knowledge that we gained in our hospital during the last, well, about 10 months about COVID-19. So first of all, I will start to tell you something about the virus and about the characteristics and epidemiology of the virus. As you all know, the new coronavirus was found for the first time in 2019, and the onset of this pandemic started in China. Within a few months, it spread all over the world, and that was also caused by our own behavior, by traveling all over the world. So the virus is called SARS-CoV-2, and the disease is called COVID-19. And this disease is mainly a disease with pulmonary symptoms, but also other organs can be involved. So the incubation time of this disease is between 2 and 14 days, but usually it's about a little bit less than a week, 5 to 6 days. We do not know exact how long the duration of the contagiousness is. It is extended in immune-compromised patients. So these patients, they do spread the virus and shed the virus longer than immune-competent patients. And it is what we found in serious illness patients with serious disease who were admitted to the hospital is that after 10 days of illness, we do find neutralizing antibodies. So we suspect that then the contagiousness is much less, but we are not sure about this. We don't exactly know this. So how is this disease transmitted? It is transmitted via droplets and aerosols. That's what we know. So by sneezing, coughing, singing or shouting, these droplets and aerosols are spread. But other routes of transmissions were also described. We are not sure about the feces or about transmission through surfaces. We do know that the virus can be spread through different surfaces, but we do not know how long these viral parts remain viable on different surfaces. So transmission can take place through mildly symptomatic, but also through heavily symptomatic patients. So even patients with mild symptoms and even asymptomatic patients can transmit the virus. And that can be a big threat, because if you don't feel sick, then you can consider to go out and do your normal daily practice where you can spread the virus. So the virus is spread from humans to humans, but also from humans to animals and the other way around, from animals to humans. And that's how we suspect that the virus was first found in humans. So if we look at the epidemiology, This is a graph of yesterday. If we look at the active cases on the 26th of October, so one day ago, what you can see in this map of the world is that the virus is found all over the world, in all different continents, in different countries. The virus is everywhere. Smaller dots represent smaller amounts of positive cases. Bigger dots represent bigger amounts. So there is a big hotspot in Europe, but also in Northern America, and parts of Southern America are very seriously infected with this virus. The problem with this chart or with this graph is that numbers that are represented in this graph are only the numbers, the official numbers that were recorded at in different countries, but sometimes the numbers are not reliable. So sometimes the numbers are not correct, and the registration is not complete. So that's always the critical note that we do need to make when looking at these type of graphs. So how can we evaluate how a country is doing in this pandemic? This is a big challenge. We can look at it in different ways. Of course, we can look at the absolute numbers of deaths or the absolute numbers of positive tests. And of course, that does show something about the amount of patients that were infected. But we can also look at the relative numbers. So the percentage of positive tests among all tests that were taken, or the percentage of deaths amongst all the infected patients. But again, we do need to make a critical note that the registration needs to be complete, otherwise these numbers are incorrect. So also limited test capacity can result in incomplete and unreliable numbers. So if you are not able to test all the patients that you would like to test, then the confirmed positive amount of patients is not correct. So then the numbers are again unreliable. So when we look at what type of patients and what type of people can be infected, then we found that people of all ages can be infected, but mainly adults are symptomatic. The mortality is not exactly sure, again, due to the reasons that I just talked about, that the numbers are not always reliable, but it seems that the mortality is less than 2%. Furthermore, children and adolescents can also be infected, but they are not the main factor for spread. Of course, they can pass on the virus to the more frail elderly or other people who are a bit more at risk for a serious course. So when children are symptomatic, make sure that they stay out of touch with the frail people who are at risk for severe disease. So a little bit more about the clinical picture and about the symptoms. As I said, the infection mainly is presenting as infection of the upper or the lower pulmonary tract. So that means that this infection can very much look like a cold. Patients experience cold symptoms, coughing, shortness of breath, and can of course have an elevated temperature or fever. And one particular finding that we see in COVID-19 patients is the loss of taste and smell. But also other organs can be symptomatic, such as patients can experience diarrhea, but also nausea, vomiting, loss of appetite, and even skin abnormalities are seen. Then the seriousness of symptoms differs very much per person. It can be very mild, from aspecific complaints or even asymptomatic, to very severe, with a severe pneumonia, septic shock, ARDS, and also many thrombotic events are seen. So the seriousness is, we don't know in advance how serious patients will be sick. So the course of the clinical pictures contains different phases. The first phase is the incubation time, and that's from between 2 to 14 days. Patients are asymptomatic in this period of time. Then afterwards they do experience symptoms, and usually the symptoms are mild. Sometimes fever, sometimes a cough, sometimes a running nose, and it takes about 7 to 10 days. Then afterwards it can be different, either a clinical deterioration or patients recover. And then if patients deteriorate, they usually deteriorate due to complications such as respiratory insufficiency or thromboembolic events, or even renal failure can occur. So how do we know which patients are at risk for a serious course? Mainly that's the patients with an underlying chronic illness. It can be different organs that can be at risk: cardiac illnesses, renal illnesses, pulmonary illnesses, of course, or liver disease. Many different underlying illnesses can cause a serious course. Of course, also immune compromised state and diabetes, elderly patients of 70+, but also untreated HIV patients. And what we found is that patients with obesity are also at more risk, at higher risk for a serious course. The outcome is worse in these patients. So how do we detect this viral infection? There's 2 strategies that can be used. The first is to use a PCR. In using a PCR, you detect the viral RNA. So we do not have any information about the contagiousness. We do not have any information about this virus being alive or being dead. The only thing we detect is viral RNA. So if you do have a positive PCR, then you do know that at some time, you don't know when, but at some time, this patient was infected with this virus. Then the next strategy is to use serology. And using serology, we look at antibodies against this viral RNA. So if someone has antibodies against this viral RNA, you do know that the patient was infected in the past. But during the time, these antibodies disappear in the blood. They disappear from the blood, but the memory cells, the memory B cells, are probably able to reproduce antibodies again in case of a new infection. But we are not sure if that indeed works like that. So if a person has negative serology, it doesn't rule out previous infection, since the antibodies can disappear from the blood, and the patient might still be protected. We see that the antibodies disappear in about 3 months after the first infection. So when we look at the patient and we want to do some physical diagnostics, we want to assess how serious this infection is. When doing the physical examination, we can very importantly take a look at the respiratory rate. The respiratory rate usually should be between 9 to 14 per minute. If it's increased, then the patient is in distress and has trouble breathing. Then, of course, also we can take a look at the oxygen saturation. Normally it should be above 94%. This can also be decreased when patients are infected with COVID-19. One thing that we found in our hospital and in the wards and emergency department is that patients do not experience a shortness of breath, but the respiratory rate can still be increased. So patients do not complain about the shortness of breath, but if you look at the parameters such as respiratory rate and oxygen saturation, you can still find that this patient is at risk and can still be very sick. So once we have found an infection with COVID-19, then of course we would like to treat the patient. So a little bit about the therapeutic options. Supportive care is most important by far. And furthermore, it's very important to prevent complications. We don't have an exact antiviral therapy. We cannot cure the patients. The patients have to become better themselves, and all we can do is give some supportive care. So when a patient has only mild symptoms, again, supportive care is important, such as antipyretic medication, antiemetics, painkillers. We have to optimize oral intake, and if necessary, we could rehydrate the patient. We do not have any specific antiviral therapy available, so we cannot treat the patient with those medications. Then it is very important to prevent transmission to other people in order to limit the spread of this virus. Important in the prevention is keeping distance from other people, both in public but also at home. And furthermore, we have to prevent the spread of droplets in order to prevent the spread of the virus. So we should not sing and we should not shout. If a patient has more severe symptoms, and that by meaning moderate to severe symptoms, we mean there is an indication for admission into the hospital. Again, in these patients, we do have to give supportive care, which is the same as with the mild symptoms. But then there's other medications that we can use as well. When a patient is admitted to the hospital, we can give the patient dexamethasone or different types of steroids like prednisone, 6 milligrams per day for 10 days of dexamethasone, and that's the equivalent amount of prednisone is 40 milligrams a day, and we give that for 10 days, but only in case of oxygen therapy, and when patients have been sick for over 7 days. Then we can give remdesivir for 5 days, also only in case of oxygen therapy. There are some studies that show a beneficial effect of remdesivir in admitted patients, but well, it's not such a big difference. But well, in our country, we do treat patients with remdesivir. Then furthermore, we give the patients antibiotics in case of a suspected pneumonia. And that's broad-spectrum antibiotics such as amoxicillin and clavulanic acid. And again, in these patients, it's also very important to prevent transmission to other people. Not only people from the same household, but of course also to medical staff in order to prevent other patients to become sick. Well, if we then treat the patients, we have certain targets of therapy. We try to get the oxygen saturation over 92 to 94%, and then also a respiratory rate below 20. So it might be a bit higher than normal, but it should be below 20. Then the prevention of complications is important in order to prevent the deterioration that I talked about earlier. We do treat all patients with prophylaxis for thromboembolic events with, for example, low molecular weight heparin or unfractionated heparin, depending on what is available in your country, with a high prophylactic dose. Furthermore, again, very important, the prevention of transmission to other people, like I said before. When the patient does deteriorate, of course, you can go to a different department and you can treat the patient in intensive care unit. And sometimes patients still have to be intubated and ventilated invasively. That is out of the scope of this presentation, so I will focus more on the treatment on the ward and at home. So how do these patients then recover? Patients can experience persisting complaints for quite a long time. It takes quite a while to recover their endurance. Patients can have concentration disorders, can have a fatigue, and do experience trouble in doing their daily practice again. We don't know about the long-term course of recovery of over a year, since it's been only less than a year that this virus was first found. So we don't know any details about the long-term recovery. So then just a little bit about the reinfections. We call it a reinfection if one patient is infected multiple times with the same virus. Several fatal, even some fatal, but also non-fatal reinfections have been described, though not on a large scale. And the patients that had a reinfection that were fatal were mainly immune-compromised patients. So yeah, that is of course a big risk factor for a serious course. Something about the prevention of disease. I already talked about it, I already mentioned it several times. This is a graph where you can see some of the main items in order to prevent the spread of this virus. Hygiene is very, very important. I will talk about some of these items a little bit longer. Hygiene is very important in order to stop the spread of the virus. You can wash your hands with soap and water several times a day. This prevents the spread of the virus through hands. It's a good idea to stop handshaking and avoid physical contact with others in order to prevent the infection of other people. And again, with the droplets and aerosols, if you cough or sneeze, do it into your elbow. Then use paper tissues and discard them after use. I have to say that no of the mentioned prevention strategies was studied extensively. So even the social distancing, we don't know whether 1 meter is a correct distance, or maybe 1.5 meters, or maybe 2 meters. That was all not studied extensively, but we do know that some of these measures work. So a little bit more about prevention. Keep distance from others. The social distancing seems to work. We found that since the time of COVID-19, there is a lot less influenza. So other viruses are also spread less in a very more limited way than usually. Then prevent the visiting crowded places, both indoor and outdoor. In crowded places, patients or people are used to talking a bit louder and thereby spreading more aerosols. Screaming, shouting, singing are also activities where many droplets are formed, so don't do that, and prevent the transmission by preventing spreading droplets. And very important, when you are symptomatic, when you have symptoms, when you feel sick, stay at home, self-isolate yourself, and get tested if possible. Because when you know that you're positive, you can even be more aware in order to prevent the spread of this disease. So I would also like to mention the super spreading events. What we found in Europe is that there are certain types of super spreading events, and that are events where on a large scale people are all together in one area and singing, shouting, and the religious services can be one of the examples, but also big parties where patients or where people are singing, shouting, screaming, and thereby infecting other patients through the spread of these droplets. Don't do that. Don't go there. Prevent the spread of the virus in that way. So if you do have to work or have to take care of a patient who is infected, use personal protection equipment. What we use in our country is face masks or face shields. We use protective glasses. We use gloves and a protective apron or a protective coat, depending on the type of activities that you are doing when nearby such a patient. So use the protection materials when you are in physical contact or when you have to take care nearby of a patient with either a proven or a suspected infection in order to spread the virus and also in order to prevent yourself from being sick. So maybe you already heard something about the vaccine. The vaccine is work in progress. So far, there are several types of vaccines being developed. And the results so far are promising, but we are not there yet. In several continents, there are vaccines being developed, and we hope that in maybe the first part of 2021, the vaccine will be available. So this is the overview that I wanted to give you. I wanted to tell you something about the characteristics and epidemiology of the virus. Also the clinical picture and symptoms I talked about, and the therapeutic options, and very important in this virus, the prevention of getting sick, of spread of the virus. That's a very essential part of getting control of this virus. So I can imagine that there are some questions. There will be a little bit of time, I think, for some questions. If there's any questions that you have and that are not addressed, you can always ask the questions via the PUM mail. Liesbeth has the nursing expertise and she can answer the nursing questions, and I will answer the medical questions, and I have the medical expertise. So I would like to thank you all for attending this webinar. If you have any further questions, you can always address them to the email address shown. And I think there is some time for the first questions.
Yes, there is some time for the first questions. Patricia, can you see the questions on the side? So it starts with, what advice is given by you to patients who are tested with asymptomatic COVID? Yeah.
Yeah, thank you, Frits. Indeed, I can see the questions. If patients are tested positive and if they are asymptomatic, basically the advice is to do the same as with the symptomatic patients. So patients should self-isolate, if possible, at home, and stay out of contact with other people in order to prevent the spread of the virus. So take good care of yourself, have some rest, make sure there is someone to look after you who can, for example, prepare some food, can give you medications or antibiotic medications if needed, and also someone who can see it if you're doing not well. If you might have to go to hospital, it's important that there's someone who can look after you. So keep the distance from other people, but make sure there is someone who can keep an eye on you.
You can continue with the other questions.
Okay. So someone asks, what about fatigue as a symptom? Fatigue indeed is a very often seen symptom of this infection. Sometimes it can even be the only symptom of the infection. It can also be caused by a low saturation, a low oxygen saturation. Patients do not experience a shortness of breath, as I said, but do experience fatigue. So we do see that very often. Okay, so then one of the questions is, if the incubation time is 7 to 14 days and only afterwards symptoms might develop, is it possible that you only develop symptoms after 14 days and be asymptomatic the first 14 days? We do know that the incubation time is between, well, not even 7 to 14, but let's say 2 to 14 days. So some patients do experience symptoms and do experience sickness after only 2 or 3 days. And for some patients, it takes about 14 days. So we do not exactly know why some patients have a shorter incubation time and other patients have a longer incubation time. Of course, you can also remain asymptomatic. Sometimes what we see is that a patient becomes positive and becomes infected after, let's say, 3 days or so. And then the first phase, so the mildly symptomatic phase, takes about a week. So it can even be that patients who are admitted to the hospital are already in the second phase after 10 days. So we don't know why that is, but it does help to talk to the patient and ask the patient, when did your symptoms start? Because then you can sort of estimate in which phase this patient is. Is he in the first phase of the mild symptoms, or has he already experienced a deterioration and he might be in the second phase? Why is that important? Because if a patient is in the first phase, you can still wait for clinical deterioration. If a patient already is in the second phase, then you don't expect another deterioration anymore. So it can be important to estimate in which phase the patient is. I hope that's enough answer to the question. So then I will go to the next question, and that's Christina asked the question that they see a delay of worsening in immune-compromised patients, liver cirrhosis and cancer patients of 10 to 20 days. And lately, many patients claim that they were sick only 1 to 3 days, but have a full-blown COVID pneumonia with respiratory insufficiency. So they don't really adhere to a 7-day rule in corticosteroid treatment. We do also see a different clinical course in immune-compromised patients. Their immune system is different, it's not working optimally. So, of course, the clinical course can be different compared to non-immune-compromised patients. So it indeed can be different. And well, I think it's always, you always have to look at the patient individually, and there's this standard rule of 7 days for the treatment of corticosteroids. Sometimes it can be shorter, sometimes it can be a bit longer. It depends a bit on the individual patient, but this is what we use as a rule of thumb in most of the patients. But many of the immune-compromised patients were not included in the studies that were published. So it can be a bit different for the immune-compromised patients. So then one of the questions is, for how long is it possible to spread the virus after you get infected with it? Well, I wish I could answer that question. That is also what we would like to know. We are not sure about the contagiousness, about the duration of contagiousness. I wished it was very short, but we do find that as long as the PCR stays positive, we know that the virus, or at least there is viral material in your nose or in your nasopharynx, but we do not know whether that material is alive or whether it is dead. So we don't know how long patients remain contagious. What I do know is that in our hospital, when patients were admitted, so we consider them having a moderate severe to severe disease, what we find is that after 10 days of sickness, of severe sickness or moderate severe sickness, we find that over 90% of the patients has neutralizing antibodies. And that means that we cannot culture the virus anymore in vitro, meaning that we consider the patient as less contagious after at least 10 days of symptomatic or heavily symptomatic, meaning patients need to be admitted. But we have not carried out a big study or double-blindly studied this item, this question. So it's only an observation. One of the questions is also, do we give antithrombotic prophylaxis to patients after discharge from the hospital? And if so, only for 14 days or longer. Usually we do not give any extended prophylaxis. Also because we consider the patients being mobile enough to not need any further prophylaxis. So in our country, it's not common practice to do that. When patients are discharged, we stop the prophylaxis of antithrombotic medication. Of course, it's different when patients are moved to a nursing home or so, where they still remain in bed most of the time. Okay, so another question is about the PCR test and the position of the antigen testing. Well, that's the antibodies that I talked about. We do use that test every now and then, but not standard care. Usually when a patient has a positive PCR, and that's what we do in our hospital when patients are admitted, also in order to carry out the correct isolation actions. Then we start by doing a PCR, and sometimes we do antibody antigen detection test, but it's not standard care, only if we want to know if a patient maybe has recently been through one of the infections. So I must say we do the antibody test and not the antigen test. We do not detect the viral RNA itself. Another question about the position of the breath test by VOCs. I'm afraid that I cannot answer these questions. We do not use this test in our hospital. I'm not sure if any big studies have been carried out so far, so I'm afraid I cannot answer the question. I can go and look it up in the literature, but right now I do not have an answer to that question. Then someone asked about, let me see, about the test results, false negative and false positive, and the divergence between the tests like PCR, snel test, and antibodies. Well, that's an interesting question. We do know that always a certain percentage of tests are false positive, but also false negative. So what we do in our hospitals, we do this PCR test in patients who are suspected of having COVID-19 disease. If we have a positive, if we have a negative test, but we do still suspect this patient being positive, then we repeat the test after 24 hours. But what we found is that only in, I think, about 5 of, I think, maybe 1,500 tests became back positive, but then we still doubted whether that was the same infection, and that was not an infection that that occurred later on. So we stopped doing a second PCR within 24 hours because we found that it costs a lot of tests and it doesn't give us a lot. It doesn't give us many new positives. So we stopped doing that. The amount of false negative or false positive is also determined by the prior chance of finding a positive test. So if, for example, in summer in my country, we did not have a lot of COVID, so then the chance of finding a false positive test or finding a false negative test was quite high. Currently, we do have a lot of COVID-19, so then having the chance on a false positive test or a false negative test becomes lower because we test more patients that are at higher risk. So it has to do a bit about epidemiology and chances. But if you carefully select the type of patients that you would like to test, that also increases the true outcome percentage of your test. So the reliability is increased by selecting the correct population that you would like to test. So I would not advise to go and test anyone, but only test the patients who you think are at risk or who were in contact with proven COVID patients. Then one of the further question is chest pain a symptom of COVID-19 in adults? It can very well be, but you also have to be aware of the differential diagnosis. Sometimes patients can have thromboembolic events such as a pulmonary embolism. That can of course cause chest pain, but also you have to be aware that patients might have a myocardial infarction or myocarditis or other complications from the heart due to this COVID-19. So I would advise to do your diagnostics, but to also keep your scope wide open to other diagnoses as well. Then also an interesting question, if a patient loses his smell or the smell sensation but have no other symptoms, what actions can we take? So if you have a patient who is confirmed positive and has no smell or taste, then I would advise the same rules as for asymptomatic patients. So do self-isolate the patient and be careful with spreading the virus to other patients. What we do is when patients have symptoms for 10 days or more, and the only resulting symptom is the loss of smell or taste, then we do consider them safe in contact with other people. So if it's 10 days or longer and the only symptom is the loss of smell or taste, then we do release the patients and they can go and do their daily practice again. One of the questions is body ache or severe muscle spasm symptoms of COVID-19? I think generalized body ache can indeed be one of the symptoms, one of the very aspecific viral infection symptoms, and it can be a bit like influenza as well. General symptoms, not very specific, and body ache can and muscle aches can also be one of the symptoms. Muscle spasms, I don't really know. I haven't seen that, but it probably can be one of the symptoms. But it's usually not the most important symptom. Then one of the questions is also, why are less patients becoming symptomatic in the developing countries? Well, that's also an interesting question. I'm not exactly sure if that is really true. I think one of the items that is a problem in the developing countries, not only in developing countries, by the way, also in the developed countries, is the reliability of amount of tests. As we know, is that, for example, in the United States, in the beginning, the president sort of denied COVID-19 of being a severe disease. There was not enough testing capacity, so we don't know. Of course, there were not less people infected, but we just didn't test them. So then we didn't know how many patients were infected. So it might look that maybe less patients or more patients are symptomatic or asymptomatic, but basically we don't know because we didn't test enough. And that's one of the problems that we find these days. If we are currently in a second wave of COVID-19 infections in the Netherlands, and we try to compare this wave to the wave in March, April, the first wave. But it's very different because in the first wave, we did not have enough testing material. So we don't know how many patients were sick, maybe symptomatic, maybe asymptomatic, or not sick enough to get tested. So it's very hard to compare this wave with the previous wave. And I think that's one of the problems in the developing countries as well. So I'm not sure if it is exactly true that less patients are getting symptomatic or whether there's a registration problem in the countries. Okay, so the next question is that in some countries there are no new cases of COVID-19, and in other countries there are still, the new cases are still increasing. How do I think about the situation and how the appropriate strategies to prevent and achieve new cases? Well, that's I think our country again is one of the unfortunately not so good examples. We did have many new rules and restrictions from the government, but unfortunately not everyone adheres to the restrictions. And we do still find illegal parties and many new, mainly younger people, adolescents, that think they're not getting sick. Well, maybe they're not getting sick of this COVID-19, but they do pass on this virus to their parents or to their grandparents. So it's a bit sad that the healthcare workers are doing their best and trying to get control of this pandemic, and other people, well, They just they are tired of COVID-19. Well, so are the healthcare workers, but well, we cannot stop. So it's one of the problems even in our country as well. And with respect to the 0 new cases in other countries, I think it is important that your population adheres to the restrictions. We do find we had a lockdown in April in our country, and it worked. We did limit the spread of the virus, but now no one wants a new lockdown, so they just don't adhere to the rules. So I think if everyone adheres to the rules, it would prevent the spread, and it would be easier to limit the infection. But people are tired of COVID-19, but it's not done with us yet. So one of the questions is also, what is known about the general dynamics of IgG antibodies for COVID regarding persistence and immunity? Well, it's also an interesting question. Basically, I don't know. I'm not sure if it is all known. We do find antibodies, and we do also see that they disappear from the blood again. But we did not find many patients who proven that they, well, as we say, that they met the virus again. So patients who were infected in the past, then recover, then meet the virus again, but do not get sick. That's what you would like to know, how the antibody response is in those patients. But we don't know. I don't know if there's any study on that. I could go and look that up, but I don't know the answer of that just now. And then someone asks, is it sensible to use medication in patients with mild symptoms still at home to avoid hospitalization because of the badly needed beds for non-COVID patients? So early start the use of dexamethasone and heparin. That's also something that we ask ourselves, and a nice question. I know there are studies that that looked at the beneficial effects of dexamethasone or steroids in the non-admitted patients, but the additional value is very limited. So it depends on how much dexamethasone is available in your country. Even in a country like the Netherlands, where we do have many steroids available, we do not give it to the patients who are at home because many patients do recover themselves. So we only find there is an indication for the steroids if patients are that sick that they need to be admitted into the hospital. And the same for heparin. If patients are not as sick that they need to be submitted, then we consider them being mobile enough not to need the prophylaxis of heparin. And also what we found is that that in the mildly sick patients, we do not see as many thromboembolic events as in the more severe sick patients. So the question is whether it is indicated to treat those patients with heparin as well. Then someone asks, are the symptoms the same on recurrent infections or do they become adverse? I don't know. I haven't seen any of the reinfected patients myself. I can imagine that it can be the same because the virus does infect the same type of tissues. So it's mainly in the pulmonary tract and the upper and sometimes the lower pulmonary tract. So I can imagine it is the same location of the virus. We do the same tests for a second infection. So probably it is the same side of infection. So also similar symptoms. Okay, one more question. How do we treat COVID and non-COVID patients in the same hospital? As this country has not enough infectious diseases hospitals. Please give design of hospitals where we can deliver service to all patients. Well, that's also an interesting question. I didn't talk about that yet. I will tell you that in our hospital, we also treat COVID patients and also non-COVID patients. So we have different wards. And in one ward, the COVID patients or the COVID, mainly the COVID proven patients, but also the COVID suspected patients are treated in the same ward. It can be advised to separate the proven patients from the suspected patients, but preferably the patients are not in the same room, even when they are all positive. Of course, the patients can be clustered. Ventilation is a very important issue. So if you are in a hospital, make sure that the ventilation of the wards is sufficient and the filters are correctly used for prevention of the spread of the virus. So it can still be in one same hospital. Make sure that the staff who works on COVID wards remains in the COVID wards. So I would not advise to switch from normal wards or non-COVID wards to the COVID wards and back. I would separate those. Okay, so I think the time is, we have no more time. Is that correct or? Okay, so thank you all for attending this webinar. I would like to ask Frits to finish off this meeting. Oh, sorry, Ruud Verreusel will finish this meeting. Thank you.
Well, hello everybody. My colleague Frits introduced my name. This is my face, or here I am in person. Well, Patricia and Liesbeth, in my opinion, you have presented a very good insight in the disease COVID-19 in a very clear, accessible and understandable way. Thank you very much for sharing your actual and professional knowledge with so many people in the world. I think we succeeded in sharing very important information for medical doctors, nurses and paramedics all over the world, especially in the countries we support as a PUM organization. And I hope this webinar is helpful in your treatment of COVID-19 patients and taking the necessary measures to prevent further spreading. If you receive further more relevant questions in the Q&A, we will send them to the speakers of today and you will get an answer. And next Thursday we will send a mail to all the participants with the presentation, a link to the recording of this webinar and a link to sign in for a certificate of being participant of this webinar. So that brings me to the end of this webinar, and we as an organizing committee want to thank you for your showed interest in this webinar. If there are new relevant developments in the next future, of course we will organize an update on this topic. So again, thank you for joining us. Keep healthy and a nice day.